and this is the time to move on to the interesting panel discussion. We already have the cases with us. The moderator for the panel will be none other than Dr. Raja. Dr. Raja is Director of Medical Oncology at the Apollo Cancer Hospital in Chennai. He is a father figure for me as far as medical oncology at least is concerned, because I began my career in oncology under him. I may not be able to do everything that he has done so far in his career, but at least I try to match up with him in whatever little way I can. So he is my mentor, continues to be my mentor, and will always be my mentor. Dr. Raja, for you. Sir, please take over.
Thank you, Senthil, for that very, very kind introduction. And I mean, it's an honor to have taught you something somewhere at some point. We all know that how much you have done for oncology in this country. First of all, I want to thank Dr. Sendurai Mani, Dr. Sevanthi, and also Dr. Padmaja for inviting me to be in this group. It's a great honor to moderate this first panel, and as I wrote in one of my mails, this is a really star-studded panel, and some of them I really look up to, and oftentimes whenever I have difficult cases, I would call some of these gentlemen and ladies for it is a great opportunity and honor to moderate them for a case-based discussion.
I'm just going to quickly introduce your panel and just acknowledge the others who have joined. So I see, first of all, thank you, Massimo. That was a lovely presentation. I would just like to say, Massimo, Ray, Dr. Razel Kazrock, Dr. Vivek Subaya, they've been a guiding light to this initiative, and really grateful to all colleagues who have joined. As we move over to Dr. Raja's moderation, I would just like to thank everyone who has joined in the attendance. I see Dr. Rajappa, obviously, I see Dr. Balazs Halmos, my senior colleague from Colombia. Balazs, thank you so much for joining in. I see Dr. Amit Verma.
You're listening in from the side.
Yes. Sorry?
I'm here. Thanks for having us. I'll be just listening.
Thank you for joining in, Balazs. Such an honor. I see Dr. Amit Verma, who's going to join the panel. He's a star molecular oncologist trained at MD Anderson Cancer Center and now at Max Hospital, Delhi. We all look up to you, Amit, for your recommendations. Thank you, Nitesh, for joining in. We will see Nitesh in action in a little bit. Dr. Paul Hoffman from France has also joined in. Honored to have you, Paul. Really, truly. Such a pleasure to have you this evening. Dr. Shaina Dawood from Dubai is joining in. She's a panelist on this great panel. She is a senior medical oncology consultant and head of medical oncology in her hospital. She's president of UAE Cancer Congress and co-president of Asia Pacific Breast Cancer Summit. We have Dr. Sudeep Gupta, the doyen of breast oncology, and he's the head of ACTREC and world leader in breast cancer medicine. We have Dr. Umar Dizel from a star precision oncologist from Turkey. We obviously have we're graced by Dr. Vivek Subaya. Thank you, Vivek, for joining in. And back to Dr. Raja to take the floor for the next moderation. Thank you.
Thank you, Dr. Sevanthi, and we'll move on with this case presentation. I thought the way we will do is I'll present the case. First, I'll present the case to all of you, and then I will, in the first 7 to 8 slides, and then I'll summarize the case, what exactly we did all along, and then we will come to the individual part of the case flow and how we managed. It is mentioned here, but then how would you have approached each one of those time points? That's the way I want to handle this discussion. And this is a 37-year-old young lady who presented with a skin change in the left breast and a 3-centimeter tumor. And she had a mother and aunt both having ovarian cancer and treated and still surviving. And then she was noted to have a 3-centimeter tumor in the left outer quarter of the left breast, and clinically palpable and mobile lymph nodes 2 centimeter. And her biopsy turned out to be invasive carcinoma, grade 3, ERPR, HER2 negative, and FISH negative, and Ki67 35%. Therefore, she was clinically CT2N1 M0 and stage 2B. So she went on to receive neoadjuvant chemotherapy, EC, followed by 12 cycles of weekly paclitaxel and carboplatin. And the clinical and imaging showed a very good response. And at that time, a germline BRCA mutation was also, panel was sent, and the report was pending while on chemotherapy. After the treatment, after the good partial response, she undergoes surgery. And then at surgery, she was found to have residual invasive carcinoma 15 millimeter in the left breast, but otherwise the lymph nodes were all negative, 14 lymph nodes. She went on to receive adjuvant radiotherapy, and then she went on to receive 8 cycles of capecitabine. And that is the scan, that is pre-neoadjuvant chemotherapy and post-neoadjuvant chemotherapy, as you can see. And the BRCA testing came in. The BRCA testing showed BRCA1 mutation, a heterozygous pathogenic variant was detected in the exon 20 of the BRCA1 gene. And this was deemed pathogenic. And then she was fine for 2 years after the initial treatment. She relapsed after 2 years, multiple lung, bone, mediastinal lymph nodes, and one of the lymph nodes were biopsied, confirmed, and it was morphologically compatible with the breast primary, and the Ki67 had gone up to 80%. And in that lymph node, a PDL1 was also done by SP142, and it was positive. And so she had the first progression. In the first progression, she was treated with atezolizumab and nab-paclitaxel. She achieved a good partial and durable response, and the response endured for about 13 months. And these are the scans on the first progression. You can see the pre-treatment PET-CT scan and the post-treatment PET-CT scan, and a good response for about 13 months. Then she went on to have second progression. And second progression, again, she had quite a bit of symptomatic disease, and therefore she was chosen to be treated with next line chemotherapy with carboplatin and gemcitabine. She had 6 cycles. She achieved a partial response and good symptomatic relief, and then but the response endured for only 6 months. She progressed on the next PET-CT scan, and at that point, she was not keen to have any more intravenous therapies. And as you are already informed, she had a germline BRCA1 mutation. So therefore, she was started on olaparib. And with olaparib, she achieved a good partial response, which lasted for about 9 months. So that was the third progression. But eventually, even after olaparib, she went on to have the fourth progression, and this is the extensive disease. And right now, she is 41 years. And at that time, I mean, while she was on the third progression, those lymph nodes were sent for a tissue NGS from the foundation one, and we have the NGS panel here. And we will look into the NGS panel in detail later. And this is the NGS panel in toto. You would see that in essence, the NGS has got a PTEN and a PIK3R1 and a Notch2 and TP53 mutations present. And as already mentioned, PDL1 is positive. And so that's the summary. A 37-year-old lady with a stage 2B triple negative breast cancer, and went on to receive the sequence of treatment. So as mentioned, so we will come to each one of the clinical journey point. And so I'll begin with my, with my very esteemed colleague, Dr. Sudeep Gupta. We all look up to him, for mentorship and some excellent clinical guidance. I have always used him for some very difficult cases. Thank you, Dr. Sudeep Gupta, for joining us. And so we saw this late-breaking abstract today. Dr. Gupta, in the advent of today's abstract, would you be considering that this patient, in retrospect, we should have put the patient on adjuvant olaparib? What is your thought, Dr. Gupta?
If this data was available when you had treated this patient, then yes, I would have recommended that she could have been offered adjuvant maintenance olaparib for up to 1 year. Yes.
So at this point in time, the adjuvant data is suggestive of invasive disease-free survival to a percentage point of 8% as published today, and disease-free survival to a percentage point of 7.1%. But the overall survival data is probably emerging and very nascent, 3.7. So at this point, do you think this is convincing enough, Dr. Senthil? What is your thought on adjuvant olaparib, today's hot news? That's why I'm coming to this question.
Correct. So I agree that it is really hot news, but I think you're showing the forest plot there. So the question also that we need to think about and discuss is, the platinum-based chemotherapy, whether there is benefit for olaparib in patients who've had platinum-based chemotherapy or not. I do understand that this might be an unplanned subset analysis with a smaller group of patients with not too many events as of now. But I think that is something that we cannot ignore at this point in time, whether the benefit of olaparib will be there in patients who have had platinum as part of your chemotherapy, like your own patient who had neoadjuvant paclitaxel and carboplatin. So that's something that is food for thought.
Yeah, absolutely. That's the forest plot, as you rightly pointed out. Where while most of the subset would be left of the unity, the platinum-based prior chemotherapy is not in favor of adjuvant olaparib. So we'll turn to Professor Cristofanilli. Professor, what is your thought on adjuvant use of olaparib in a patient, if suppose this patient had not been exposed to platinum therapy?
Yeah, no, first of all, a couple of considerations. Clearly, this study is going to change the practice for triple negative BRCA mutated. This irrespective of the platinum base. I think we are still debating if we are going to use platinum or not for the neoadjuvant treatment of these patients. But the data is so strong that the drug is going to be approved, and there will be no way that we're not going to provide olaparib for these patients. The second thing is the practice is actually changing as we speak, because as you know from the Keynote 522, the immunotherapy now can be used as a neoadjuvant as well as the adjuvant phase for triple negative. You can see an improvement in event-free survival. This is going to be bringing the approval of pembrolizumab in the early settings. So how do you interpret these cases? How do you treat these cases in the context of germline mutation? You're going to give pembro together with olaparib. So it's something that we need to learn really very soon. There will be probably other studies looking at the combinations in the adjuvant setting to improve even more the outcome of this patient. The other thing for this particular patients, as you know, there is now a study that is open for patients with BRCA mutations as well as no BRCA. They had first-line immunotherapy with pembro and combination chemotherapy, and the best response, they actually go in randomization with the olaparib and pembro versus continuation, the same therapy, same combination with pembro. So that would have been, if it was available, obviously an opportunity for this patient to see if we could combine pembrolizumab together with olaparib and improve or extend the response to first-line treatments. So different opportunities that you see, I think the standard is changing, and there are so many different options that would be difficult to slice the patient with prior carboplatin or platinum compounds, with prior immunotherapy, and with immunotherapy already in the advanced setting.
Thank you, Professor. Excellent insight. I'll turn to Dr. Sahina.
Dr. Raja, can I just make one very quick point? Whenever we look at these forest plots, one cannot, look at this subgroup analysis in isolation of what is crossing the line of unity. There is no proof that there is a test of interaction or that, the prior platinum use interacts with the benefit of olaparib. So I would strongly urge everyone not to look at this subgroup analysis, especially when the numbers are so small, and the overall results of this study are applicable to all subgroups, including including those who have received prior platinum or who have not received prior platinum. And I think, that we should not sort of dissect this too much, and there is no interaction that I can see on that forest plot.
Thank you, Dr. Sudeep. That's perfect. But we are going to talk about the interaction of platinum in the various choices. I'm going to call for some of that. As Professor mentioned, could we have done the neoadjuvant therapy itself differently? So I'm turning to Dr. Sahina. Dr. Sahina, as you know, we did the neoadjuvant in the very classical, EC followed by paclitaxel and carboplatin. So the GCAM, CalGB 406, 603, and so on and so forth. So would you have done something different if it was today, or what is your thought whether we could have improvised the neoadjuvant itself, Dr. Sahil?
So, at least in my practice, we have adopted the Keynote 522 trial for our patients who are young and at very high risk. So for us, we always start with paclitaxel, carboplatin, followed by AC, similar to what was done in the trial. And we've added pembrolizumab. We obviously don't do it for everyone, but because the response rates are higher, that's the reason why we pick and select our patients. This patient is node positive, triple negative, high Ki67, all features of a bad prognosis. So you really are trying to push that PCR as much as possible. And of course, we have that conversation with our patients that it's still not a fully approved protocol, but overall, because of the high risk of her disease, we do give them that option. So that's the first thing. The second thing is I would like to make the comment, because I always have to argue with Sudeep and Senthil. So that's always been our thing when we're on a panel discussion. Completely agree with you, Sudeep. We shouldn't be dissecting this paper out. But the fact of the matter is only 20% of the patients with triple neg actually received a platinum on this trial. And these patients all had to have residual disease post-op, so really a high-risk group of patients. So it makes you wonder whether that PARP is actually going to add anything in that subgroup of patients, because that's high cost with potential toxicity, where you do have an alternative such as the CREATE-X and the Keynote 522, where you could potentially be giving these patients adjuvant immunotherapy as well. So it sort of makes you want to think, outside the box. I completely agree with Massimo that, I'm looking forward to those trials that are looking at the combination of immunotherapy and PARP. I think that's the way to go. But of course, we need to wait for that data.
So then, that's the question. I have already, shown what you talked about, the Keynote 522 and the immunotherapy plus PARP as a way to go. Then, and we have different options there, olaparib and veliparib. Is there a sense as what could be better one over another, differential toxicities and probable slightly superiority of veliparib, Professor? Can you tell us, Professor Massimo, which way this, you talked about this combo, immuno plus PARP inhibitors. Can you tell us a little bit more?
Yeah, I mean, when you see a patient with BRCA mutation, the tumor mutational burden in this case was 8, so tended to the high for breast. We have used the two approved PARP inhibitor, talazoparib as well, olaparib, and I think talazoparib seems to be a little bit more effective, maybe in some cases even better tolerated. For some reason, has less GI toxicity for some of the patients, and I don't know if that's specific for the molecule or for the type of patients, but our experience has been that overall, beside the bone marrow toxicity, talazoparib seems to be better tolerated from patients. The other also because the doses and the ways administered. The other is so there are studies even in our institutions where we combine with a checkpoint inhibitor, and this is actually moving from the simple germline BRCA mutation to other gene mutation in the DNA repair. ATM, ATR, PAL2, etc., because there is indication that this particular DNA repair mutations in the germline, I think, can be actually benefit from PARP inhibitor and can be probably increase efficacy in combination with a checkpoint inhibitor. So we have a trial that is a basket trial, essentially getting all these different mutations above and beyond the BRCA, for which we can enroll patients, and this is again with talazoparib and pembrolizumab. So is an investigator-initiated. But I think there are a number of studies that are looking at a variety of different PARP inhibitors, including niraparib, as you've shown, together with other checkpoint inhibitors. So this is a path that is going to be explored even more. But in this group of patients, above and beyond, when you get to third line, I think Trodelvy, sacituzumab, the immunoconjugate antibody, is really a strong drug. It has overall survival data across the board. So it is difficult to argue that when you get to that point, particularly for these patients, you want to do everything you can. That drug is the treatment.
Perfect. So I'll talk to Dr. Amit. Amit is one of the most respected molecular oncologists in our country. Amit, you heard Professor Massimo's excellent, eloquent discussion about going as far as using the cell-free DNA, so on and so forth. But are we routinely ordering a full broad panel NGS in all our patients in breast cancer, at least in the metastatic setting? So what is your advice, Dr. Amit? At what point should we order a full panel NGS, whatever be the case? It could be a HER2 disease, it could be a triple negative disease, or it can even have a BRCA identified. So what's your advice, Dr. Amit?
Thank you very much, Dr. Raja. So in my clinical practice, and what I normally recommend is for the metastatic breast cancer cases and post first line failure, I think everybody should undergo the NGS just to have the more options for treatment. And for other cancers, whether it is ER positive or triple negative, for the early stage cancers, we already have clear-cut guidelines to handle them. We have the first line very clear-cut. We are not going to change the treatment based on the NGS upfront. That is one. And we also understand there's a lot of selection pressure post-therapy. So it is better when you are ready to treat the patients outside the box, you should get the NGS done then. So I would recommend that after the first line failure, metastatic breast cancer, all should undergo NGS testing, broad panel.
Okay, but we did hear how Professor told us the evolution of resistance and so on and so forth. We'll come to that. So we will move on to the first, after the first progression, we treated the patient on atezolizumab and nab-paclitaxel, as you all know, based on the IM-PASSION 130. Fine, but we also have the other choices of naproxen paclitaxel, which we had already exposed in the neoadjuvant setting 2 years ago, and then we have the pembrolizumab data. So Dr. Senthil, at this point, on the first progression, we elected to treat with immune checkpoint inhibitors and nab-paclitaxel. Would you have done something different?
No, I would have at that point in time done the same thing, because that was the time probably the IM-PASSION 130 was just out and all of us were very enthusiastic about PD-L1 testing, SP142, and then the use of immune checkpoint inhibitors. So I wouldn't have done any different. But my question, if I can ask one, is that IM-PASSION 131 was negative both for progression-free survival and overall survival. And the reason that was quoted was the kind of paclitaxel that was used and the steroid pre-medication, and of course some statistical issues. So what is the panelists' take on the negativity of IM-PASSION 131? Has that brought down their enthusiasm for this and turned to pembro as in the other study for patients with a CPS of more than 10? So
we'll come to that in a minute, Dr.
Okay. So that was my thought. So otherwise, I would have looked at an immune checkpoint inhibitor. Certainly.
Absolutely. I will actually try to tweak the question even further. What are the choices, as you rightly pointed out? What about the pembrolizumab data, particularly with the CPS score of 10? But I will turn to Dr. Sudeep Gupta to answer this question. Why not monotherapy? We have modest responses with monotherapy, but we have durable responses with monotherapy, and we now know that we can enrich the monotherapy responders. This patient, of course, had a cat on the wall TMB of 8. So what is your thoughts on the pembrolizumab data and the monotherapy at this setting, Dr. Sudeep?
I suppose you mean monotherapy with an immune checkpoint inhibitor.
Immune checkpoint.
So first, to answer your first question, I would not have treated this patient with nab-paclitaxel and atezolizumab, given the fact that she had a pathogenic mutation in BRCA1 in the germline, and given the fact that she had about a 2.5 years disease-free survival. I would have used gemcitabine and carboplatin in this patient. And if I had access to the pembrolizumab data at that point of time, I would have added pembrolizumab to that, provided the combined positive score was more than 10% by 22C3. That is how I would have treated her. And let me say that the atezolizumab data, for a variety of reasons, looks quite unconvincing to me, and I'm not really convinced that it leads to substantial patient benefit. So, there is a whole lot of statistical jugglery here. There are some analysis that ought not to have been done according to the hierarchical testing rules, etc., and so on. And when you cut up the data and you show that a portion of the patient population has a survival benefit, but the others don't, there is always a high possibility of play of chance there. And just let me in the end say that I think, again, for a variety of reasons, the pembrolizumab data looks more plausible and somewhat more convincing to me.
Okay. So, Senthil, you heard the boss speak. So, but then we will take it. We will try to up the ante with Dr. Sahina. Is there any other way we could have done something different? We heard about the pembrolizumab, and we also heard Professor talking about combos and all non-taxane backbones. Some of very interesting studies, tonic, Saphir, and so on and so forth. And then particularly, what about combining immune checkpoint inhibitors and PARP inhibitors? And so what is your take on improvising the therapy at the first progression, other than what we did?
So I don't think I would have done an immunotherapy and PARP inhibitor until I have some, concrete data to warrant it. I know the data that's out there is very, very encouraging, but that's huge cost for patients. For me, when I have a patient that is triple neg that has recurred, and especially 2 years out, I see if my patient is, and they've got PD-L1 positive disease versus a BRCA1 or a BRCA2 mutation. I look and I see if the patient is in visceral crisis or not. If the patient is not in visceral crisis and the tumor mutational burden is low, I do offer them a PARP inhibitor or a platinum-based chemotherapy if they cannot afford it. I'm more inclined to agree with Sudeep that since the results of the Impassion trial looking at Taxol and atezolizumab's come out, I'm not buying the explanation that it's because of paclitaxel that's why the trial failed. This is just a second trial that's telling us we need to be a little bit more cautious. I'm more inclined to use pembrolizumab plus chemotherapy, especially since it gives you the ability to expand your use of immunotherapy beyond using atezolizumab, which you can't really use long term. It is a toxic regimen. There is a whole question of we have an overall survival benefit with Impassion. We should be using that as first line. But like Dr. Sudeep clearly mentioned, that there's a whole amount of hidden statistical weirdness in that trial that keeps pointing out that yes, it is positive, but it's not statistically positive. So I personally, I give that option. We have also seen the post-hoc analysis of the Olympia trial that has shown that if patients have not received chemotherapy, prior chemotherapy, there is an overall survival benefit to using a PARP inhibitor in your first line setting. So again, yes, it's a post-hoc analysis. I think it's a very reasonable option. I probably would have used PARP up front as my first line and reserved my immunotherapy as my second line option. I'm
happy to hear that your second time agreed with Dr. Sudeep in the panel, even though today you said that you're going to. But as you were, I'm crossing my hands, holding my, as we do. We have done something. Okay, we did that, whatever we did, and then we went on to, in second line, we treated with gem carbo, and then on third progression, we did the single agent.
Can I ask a question, Raja sir? Sorry to interrupt. Would anybody want to use paclitaxel and carboplatin? Because if you look at the...
Senthil, 1 minute.
Yeah, sure, I'm sorry.
And that's how we managed the third progression, and then I wanted to gravitate towards the molecular findings and so on and so forth. So your question, Dr. Senthil.
So I was just thinking, paclitaxel carboplatin rather than gemcitabine carboplatin with pembrolizumab. Would anybody think of a combination like that? Because rather than gemcitabine, just a question.
Fine. So I think that question probably has to be taken by.
So can I make a point? Can you go back to the different treatment. I think there is not wrong answer here, right? Everything is questionable, but everything is right. So the patient should have received an immunotherapy. Many of us agree that probably the combination chemotherapy with pembro would have been probably better. This woman, after all, had a Ki-67 or 80% in the biopsy, so really needs a backbone of chemotherapy and progressed very early on. She needed also an NGS very early on, because you could argue that if you had a P10 mutation, you could put her in a study with an AKT inhibitor if this was available. Don't forget the clinical trials, the possibility to have clinical trials. And the other thing is, I don't see in the reports from Foundation BRCA1. Usually this appears, and we argue if this is a germline or this is associated with, is a tumor-related somatic mutation. I don't see this anywhere. And, you know, some of these molecular tests also take blood or saliva to test the germline DNA. Foundation, of course, doesn't do it, but typically, if you have a BRCA mutation patient, they will be reported somewhere in the report that you have identified this mutation. High allele frequency clearly is a germline, and so forth. Where is the BRCA mutation here?
Absolutely, Professor. That was the holy grail of this particular case. We wanted to come. Thank you for taking. That's why I completely skipped on what kind of PARP inhibitor, so on. We have come to this, and so that's the first question we asked. I mean, this is the NGS report in toto, and what we see is that there are, just to reiterate, the TMB8 mutation per megabase, and we have the P10, PIK3R1, and the Notch2 TP53. So we'll go to that, and I will ask Dr. Amit. Dr. Amit, as the professor pointed out, and as I had the opportunity to discuss with you and your good wisdom of educating me, how an NGS may not always be, this is the paper that is last year that compares the NGS and the MLPA. So can you tell us what do you think about the NGS finding in toto, Dr. Amit, and as to what Professor Massimo pointed out?
Yeah, so I think it's a interesting case where the patient had 3 lines and you are seeing a discrepancy in the germline alteration and the somatic alteration. And if you see, there is a lot of selection pressure, especially the PARP inhibitor. And so if we try to explain this discrepancy, there are 2 thoughts which come to my mind. If I talk about the technical aspect, the important aspect is the NGS technology uses 2 important technologies. One is the hybrid capture and the other is amplicon based actually. So amplicon based technology tend to have limitations. Large deletions are sometimes missed. As a vis-a-vis, the hybrid capture tends to be more, you can say, accurate. But large lesions sometimes are missed because they are more of a bioinformatics analysis. Depending upon what pipelines they have used, they may have a miss. On the other hand, the patient is a post-PARP inhibitor. There's a possibility of reversal of the BRCA mutation because in this particular, this is the base substitution what was seen in the germline test. So this is also a possibility. So technical limitations or the selection pressure, reversal of BRCA mutation, these are 2 explanations which comes to my mind. But yes, these are things which are possible.
Thank you, Dr. Amit. I've just catalogued, the TCGA and various other data for the top 20 genes status in the triple negative. So I would turn to Professor Massimo. If I have a panel like this, leaving alone the controversy of the BRCA being missed out, other than that, if I have a panel wherein I see all these, PIK3CA, not PIK3CA, it is a PIK3R1, P10, and Notch2, and so on and so forth. My first question is, are they the original drivers or are they resistance escape mechanism? And how do I come to that kind of decision making, Professor?
Well, this is the only NGS test that we have for these patients. So clearly it could be a founder mutation present in the primary tumor associated with resistance to chemotherapy and treatment overall. And I think in that case, that's why the consideration for a clinical trial or an AKT inhibitor could have been brought up at some point if this was available. I would not go and use alternative pathway, AKT pathway therapies like everolimus with chemotherapy, this is, really low level of evidence. These are not even considered, discussed much at our molecular tumor board. I think, with the triple negative, the targets that you have approved treatment or you have evidence of combination of the molecular diagnostic associated with treatment are very few. And that's why I say, you look at tumor mutational burden and NGS, you look at PD-L1 with the different antibodies. Of course, you need to run the DACO for the pembrolizumab. And at the same time, you can look at some of the resistance as a possibility to reach some of the clinical trials, not necessary to use off-label medication. Occasionally, you have this unusual finding, as I show you with the fusion, but this is very rare. And we had, for example, a couple of patients that were triple negative, and they had an HER2 mutation. So we were able to put this patient in the SUMMIT, they enrolled in the SUMMIT trial with the neratinib, and the patient responded very well. But this was a resistant mechanism that appeared later in the course of the disease after she had progressed on chemotherapy. So I think you may identify some treatment and some targeted, as I mentioned before, these antibody-based therapies, immunoconjugate, are probably helping us to treat the patient irrespective of the target available. So NGS can actually get you to the right treatment, excluding the possibility that there is a target. So you need to look at this both ways. If there is a target, reach a clinical trial or therapeutic target for which you have an approved therapy, that's great. Obviously, we know the benefit and we know the studies that go to that. But if there is not, he directs you to the best possible available therapy for that particular indication. So is an exclusion also. So it helps you to direct your management.
Thank you, Professor. We are reasonably aware of the clinical subgroups of the triple negative, and we can talk about. But it's getting deeper and deeper. You can tell us, the layman's 6 subtypes and the Fidon University classification, so on and so forth. I've just cataloged them, and the application, therapeutic application based on these classification and so on and so forth. Does that really, apply in the clinic on a day-to-day basis, or at least in a higher center like you? Where does all these stand, Professor?
Yeah, this classification clearly doesn't apply. Obviously, you can try to identify the mutation and most likely will put the patient in a specific subset or triple negative. But again, there is no really a good therapeutic target associated with the specific mutations that's been approved for that indication to show that you really need to pay attention to an MRA-derived subtype of triple negative. So there is no consideration for this type of subtypes in our molecular tumor board because we don't have the data to support that, and we don't have the information that suggests a specific subtype, except for the androgen receptor. Of course, if you have an androgen receptor, our pathologists, by the way, they test for androgen receptor. Some of the triple negative patients, they have a tissue biopsy. So we do have an androgen receptor expression. Whatever this means is not a perfect marker for triple negative disease. We do have standard PD-L1 testing, so that there is a pathology assessment with standard immunohistochemistry that in our case include androgen receptors, and there is an NGS, but we don't use the combination of this test to subtype the triple negative disease.
Dr. Sudeep, I can ask you, you are heading a most important research laboratory and clinical combined unit in the country, and you, among all of us, have the vision to pioneer in many of these areas already in a known driver disease, like for example BRCA1. When we see all these findings, be on an NGS or based on, if we get to that, ctDNA or cell-free DNA, how comfortable you are in taking it forward in a BRCA disease or a HER2 disease with all these novel mutations found and taking it forward to therapeutic decision making? Dr. Sudeep, your comment on that.
So my short answer to your question is that I'm not at all confident acting on a whole lot of abnormalities that are found on NGS, because there isn't enough good enough data for me to be able to act on those. I just want to make two short points. The Vanderbilt classification that you showed actually was not really based on the mutational profiles, but on the expression profiles of those tumors.
That's right. That's right.
And the other thing about androgen receptor that I just want to say that the mere expression of androgen receptor does not correlate very well with response to androgen blockade. It is the luminal kind of expression pattern and signature within the androgen receptor expressing triple negatives that actually predicts for response to androgen therapy. And often, these are tumors where you feel that they should have been ER positive, but, they are actually ER negative and they are AR positive. And I've had a few such patients who've responded well. And my last comment is that my PhD student is about to publish some data where we longitudinally sampled 8 patients with triple negative breast cancer through repeated relapses. And we, at each point of time, we biopsied their metastatic tumor. We also did a cell-free DNA. And we actually first performed a whole exome sequencing at 200x, looked for private mutations at each time point, then constructed a custom panel. And then for 1000 particular mutations, we did an ultra-deep sequencing at 40,000x. And the headline result of that analysis is that, the cell-free DNA captures what happens in the tumor with a high degree of accuracy. But the bad news is that each tumor is different from the next. And the degree of overlap between tumors is actually very low. So, as doctors, we wish to find some recurrent themes in tumors so that we can use some common medicines. Unfortunately, it seems that it will have to be personalized patient by patient. And, to personalize a treatment patient by patient, you need a whole lot of medications. And as Dr. Christofanelli was saying, clinical trials, but clinical trials are not accessible to the large majority of patients worldwide. They happen only in very few centers in very few countries, especially with early stage clinical trials. So essentially, we have to rely on our clinical judgment. And in a short answer to your question, I am not a great fan of looking at a whole lot of mutations in tumors to be able to treat our patients.
Okay, Dr. Sahina, this is an opportunity to, probably antagonize Dr. Sudeep. Would you want to take that? There is enough data on circulating tumor DNA and then really correlating with the prognosis response, particularly to the PIK3C AKT1 mutators. This is the Lotus trial, iptasertib data and all. And we also heard what Professor Christofanelli presented. So short question, are you a fan or not of these emerging technologies, if cost is not an issue?
If cost is not an issue, I'm a big fan of these technologies, especially I think the thing with circulating free tumor DNA is that you can track mutations over time. You can see the changes over time and you can see things emerging. But I don't know what's happening today. I am agreeing with Sudeep that I don't think it's for everyone. I think from a clinical standpoint, if you have a patient that's got minimal tumor burden, sometimes you won't catch anything. And I think we need to realize that. So it's not always applicable in the clinical scenario that we think it is. But it's also easier.
But we did see in his presentation that, something completely incongruous like an IDH1 really kind of harbinger of the MDS being detected in the patient. So I think, we have also seen this very often. We all enthusiastically send the Guardant and all that, and we get all these reports. And sometimes we don't know how to act on it. That's where we are. So I will, I have run out of my time. So I will leave the last question to Professor Christofanelli. Professor, what's the gap between the last question and the last minute? Professor Christofanelli, the bench and the clinic, your comment, and then I turn it back to Dr. Semani.
So before that, can I just interrupt just for 1 second? So, from while I agree with Dr. Sudeep Gupta that, today maybe the information is not available to reach everybody, right? Because the clinical trials are available only on a select place, select center, select institute. Therefore, it's very difficult to translate this information to everyone all around the world. When the human genome was started sequencing, Eric Lander and many others, they spent $3 billion to sequence one genome. Today in my lab, we sequence one single cell for 35 cents. Okay, and things are changing and things are evolving rapidly. So these will be available in no time for everybody. But in my opinion, it's a good idea to prepare and ready for the change rather than waiting for the right moment. So therefore, that's where the Iylon we formed, hoping that it would kind of create a platform to start, having a dialogue with the people who are doing these kind of clinical trial, and then see how that information could be implemented to the patients who may have similar situation but may not have access to the medicine, but may have access to similar medicine but not the same medicine.
Dr. Mani, but I just want to paint a different flavor here. I am in one of the tertiary care center, and at this point in time, I do not treat almost any patient who has solid tumor on progression without an NGS report, be it tissue or liquid, whatever. Having said that, the question is not about the cost, as Sahina pointed out, and even Professor Sudip Gupta pointed out. Our question to Professor Cristofanilli is actionability and making sense of what is there. So that's the crux of the question. For that, from the lab to the clinic, I would ask the last question to Professor Cristofanilli.
So I just want to comment on what has been said regarding liquid biopsy. Every tumor is different, but you don't have to use a 500, 600 genes to study a tumor and trying to compare to another tumor with the same large gene platform. You can do a digital PCR for 5 genes, hotspots, and you have the information that you need in terms of actionability. Don't you want to know if there is an ESR mutation, a HER2 mutation, a PHK mutation, a tumor has been treated with endocrine therapy in advanced setting? Yes, you must know that, because this is the way you should direct your practice. You need to find the best way to do this in a cost-effective to be available to the largest population that you treat. You don't need to do a 500, 600 gene platform, because this is research, is bench, is great publication, but is not care and planning for care. So I think we need to all find the best way to bring the most actionable information to patients in a cost-effective way. And progress is moving forward. So as Mani say, it's going to be very cheap to do this test. And it's going to be like doing a blood glucose for diabetes. So you're going to have to check your mutations like you check your blood sugar during a specific type of therapies. Even the most common type of therapy, like an AI or like a CDK4/6 inhibitor. So I think we should be ready for that, and we want all our patients to get benefit of it. But we need to, at the same time, continue research, bench research, in order to advance and to identify more target and more therapy, and maybe repurposing all drugs that may actually do better than new and expensive drugs.
Thank you, Professor, for that words of wisdom. Thank you for this opportunity, the Iylon team. I turn my opportunity to you for the next session. Thank you so much.
Thank you, Dr. Raja. This was wonderful, wonderful moderation, powered moderation, I would say. And this was very expected. This is how you're seasoned, and it was so lovely to learn so many nuances. I didn't open my mouth because there was one time when I was doing a breast cancer genomics presentation, and it was chaired by Dr. Sudip Gupta, sir. And I had to sort of put everything in moderation because I was going to go say this pathway works, that pathway works, that pathway works. And then I ended up saying, we need more data, we need more data. So I kept quiet with this, but I see Ray has joined. Dr. Razel Kurzrock is here. Welcome, Dr. Kurzrock. And with that, I thank Dr. Raja, Dr. Cristofanilli, and Dr. Senthil Rajappa, all the panelists, for the wonderful discussions that we just had.